Moving on from allergy to asthma. Sorry, we're going to run out of time if we've got the break after us, so you can all catch up then. So my name's Alison Scott. I'm one of the respiratory consultants at the Children's Hospital, and Emma, one of our nurses, is joining us this afternoon as well. So we're going to talk about paediatric asthma, which follows on nicely from what Elle was saying, largely in view of the updated NICE guidelines. And I sort of appreciated that it's a fairly varied audience. Could I just have a show of hands of who would be happy to manage asthma in patients over 12 years old? Who's pretty confident with that? Okay, and in patients, that's about half maybe, in patients 5 to 12 years old? Okay, and in the under fives? All right, okay, so we're working through all of those, and it gets progressively harder, but we'll try and keep it simple. So I'll run through a little bit of the basics of asthma, and then most of this is based around the new NICE guidelines, which you can obviously all access with a few of our local resources built in as well. It looks like a slightly odd order to do things in, but I think that's where it starts simple and gets a bit more complicated, so that's why we'll work through it in that order. And I've got some resources and some contact details at the end for people as well. So just as an example, and this is what we're working from, I've got a couple of the referral letters that we get from primary care at the Children's Hospital. And we're slightly unique that we're both a secondary and tertiary service at the Children's. So we're sort of your local paediatric service, but we also get regional referrals for more complex conditions. So this is a fairly standard GP referral. I think this is from a practice nurse actually. So includes information about triggers, whether they've needed steroids, a little bit of a history of atopy as well, and suggests that we might want to do some testing. The second example that I've got talks about wheeze, which is good, exercise as a trigger for this patient as well, and again asking for spirometry. I just want to start by saying that we are getting about 35 of these referrals a week at the moment following the new guidelines, and if this continues, we will not be able to deliver this service. So I'm going to work through the guidelines so that we can try and work together on this. And these are perfectly decent referrals, but we obviously see quite a lot of other referrals as well, so this is becoming a little bit unmanageable for us. So this is why asthma is the most common chronic condition in children, and about 1 in 10 children will be affected by it. And we know that it causes a lot of problems for people as well. It's in the top 10 causes of emergency hospital admissions. That varies by season. And about 10 years ago, there was this big national review of asthma deaths, so looking at adults and children. And they found in that study that about 46% of the children that died from asthma had inadequate standard of care prior to that. So they were deemed preventable deaths. Last year, just prior to the launch of the BTS NICE guideline, the National Child Mortality Database looked at asthma deaths. So they looked at deaths between April 2019 and March 2023, with some information from the child death review bodies around that time as well. And this is a kind of infographic, this is all online, of the main factors that were present in a lot of those child deaths. There's a lot of environmental things at the bottom right, which I think are maybe more of a political thing to address. But if we look at the more medical elements of this and the things that you probably can track in primary care as well, it was very much the adolescent age group that died. It was very much a deprived demographic that we're finding to have died as well. And I think in terms of how we can identify them between ourselves, 87% of these children had 3 or more salbutamol or short-acting inhalers prescribed in the 12 months before their death, and 65% of them had been seen in A&E or out of hours in the year before their death as well. A few more details. Boys were much more likely to die, in fact twice as likely to die than girls from their asthma. And the numbers that they looked at, although they're quite small, equate to about 1 child every month in the UK dying from asthma. Much more in urban areas, and as I've said on the other one, if they were getting more inhalers, more short-acting inhalers, they were much more likely to die as well. Linking into the care that they received. So obviously a lot of this is in the guidelines as well. So whether they received a planned review within the 48 hours, and I'm not going to enter that debate with GPs. I know that that is a largely impossible ask, but if we're talking about what should be happening, and also a lot of these children were not referred on to specialist services when they should have been, when they had one of those kind of red flag things that should have meant that they were referred on. There wasn't always an asthma action plan for them, and there was evidence of poor compliance in terms of prescription pickup, non-attendance at appointments, and overprescription of relievers, as we've discussed. From our own personal experience locally, we had, sadly, one of our patients die from his asthma last year at the Children's. And one of the predominant features in his history is that he was regularly coming in with an empty, short-acting beta agonist. He was relying on shaking it or squirting it and assuming there was some medicine in that, and actually he'd run out of his reliever. And this has been stated by the coroner as in preventable death reports. So he didn't actually go to the coroner, but nationally there is obviously now an alert out about inhaler counters. So most beclomethasone and all salbutamol in the UK doesn't carry a counter. There are 200 doses in every salbutamol inhaler, but there is no way to know when you've run out of those doses unless you count those doses. So we are we're saying stick stickers to your inhaler and put a pencil with it. It's pretty high-tech stuff at the Children's. Or put a piece of paper and a rubber band and use a pencil to keep a tally of when you're using your doses as well. We're also advising families to not over pick up salbutamol so they know how much is in each one that they've got, and ideally have school keep some kind of record as well. It was actually a problem for us. We do reversibility testing and we weren't keeping a track on our inhalers until fairly recently, embarrassingly recently actually. But there is a national alert and there's a campaign to change that, but for now I think it's really important that when you're prescribing salbutamol that's something that's remembered.
Yeah, and I think it's also important to remember that every month people are ordering the prescriptions and they're always ordering, it might just automatically generate that they're ordering a salbutamol as well. And we spend a lot of time speaking to surgeries saying that actually if they're having more than 3 salbutamol in a year, then this is a red flag to us that their asthma's not well controlled. So if we could just bear that in mind as well.
So the study last year, the National Child Mortality Database, makes a statement that I don't think any of us would disagree with, that basically we should be joining up care, and if care hasn't been joined up, it should be a never event that these children are dying from their asthma. So moving on to the guidelines. So they were released with sort of fireworks and balloons at the BTS conference in December last year. So the key thing in all of this, and this is throughout the ages, is getting a really good history of asthma to start with. So there's a lot of cough referrals that we get, and a cough is definitely asthma, but not, a cough can be asthma, but is not definitely asthma. I think wheeze is very much a key feature, and I know it's probably sucking eggs, but it's just worth checking that. Breathlessness with triggers, variation during the day, variation during the year, whether there's a family history of other allergies, nasal symptoms. The majority of these children are going to have a normal examination, but you may find some wheeze when you examine them if you're getting them on a particularly bad day as well. And I think wheeze during exacerbations is a persuasive feature, although not fully diagnostic. So if we start with the diagnosis in 5 to 16-year-olds, this is similar to what you've got for adults. And starts with pheno, moves on to spirometry, looks at peak flow, and then other sort of more specialised tests, skin prick testing or blood tests as well. The text version of this works through those and gives the kind of specific criteria to each of those, but it doesn't mean that you have to do these things in primary care. So if you don't have pheno testing, you can do spirometry. If you don't have spirometry testing, you can do peak flow monitoring. And the Asthma and Lung UK website gives a way of working out the amplitude percentage mean of the peak flow as well. So it's basically the difference in the highest value and the lowest value that they get divided by the mean and multiplied by 100. And if that's 20% or more, that's felt to be diagnostic. So that's something that can be done in primary care. Equally, a basic blood test could be referred in for IgE or for a full blood count to see what the eosinophils are doing as well. So it doesn't have to be using our diagnostic services in order to make that diagnosis in this age group, but we do obviously have these services linked to our clinics. Pheno, again, you'll be doing in adults, but I'm sure you know it needs a very specific technique, and a raised pheno is not just due to asthma. So it can be raised in other eosinophilic conditions, if there's eosinophils in the lower airways, if there's allergic rhinitis particularly, and if there's other features of atopy as well. If they don't have eosinophilic asthma, then they won't have raised eosinophils, so they won't have a raised FeNO. And other environmental factors can put it up, so particularly cigarette exposure, pollution. If they've recently done exercise, they can get a slight raise in their FeNO when they come to clinic as well. And specific types of food, including beetroot and green leafy vegetables, can put the FeNO up as well. So if it's high, it may not just be asthma. And I think the guideline perhaps slightly brushes that under the carpet. Steroids obviously can reduce the FeNO, and it would be one of the things that we'd use to monitor adherence. So if they've had a recent course of steroids, even if it's not for the chest, that could change that. This is where it gets a bit trickier. We're moving up. So the diagnosis and treatment in less than 5-year-olds, we can't do spirometry and FeNO reliably in this age group. In fact, we don't attempt to do spirometry in our clinics until children are 5, so they just wouldn't have it tried. And likewise, FeNO, we'd get fairly variable results up to about, do you think, age 7? It's probably a little bit trickier than the spirometry. So the guideline here focuses very much on a trial of treatment, and this is very standard treatment, is what you'll be used to doing. So inhaled corticosteroids with a short-acting beta agonist for a reliever. Thinking about other things that might be making things worse, so whether they've got the right inhalers, whether they've got the right technique with the inhalers, whether there's anything environmental that might be contributing to things getting worse as well. Patients to particularly worry about are those requiring frequent hospital admissions, lots of steroids, and that's kind of things to think about in terms of sending them on to us as well. But again, make sure that they're doing things properly before you do that, but we're there if we need it. So that's the algorithm that they've got on there, and essentially if they have a trial of treatment and their symptoms get better, the guideline then suggests stopping that after a few months to see whether the symptoms return. If the symptoms stay away, then just leave it. If the symptoms come back, restart the treatment for a little bit longer. And if it still doesn't control things, that's when it suggests adding in some Montelukast to see if that makes a difference to them as well. If it's still not quite under control, that's the kind of point of secondary care referral on those guidelines. The over 12s are similar to the adults, and the NICE guideline divides these into sort of existing diagnoses, which is this group on the left-hand side, and new diagnoses on the right, and this is when we're moving more to the MART regime. So there's nothing particularly surprising on the left-hand side there, and if that's working for them, there isn't a massive push to change that, but it's worth considering whether patients may benefit from moving to a MART regime. The new diagnoses, the first line now is the AIR and MART therapy in the over 12s. But before doing that, think about other things that might be making things worse, and particularly in the over 12s. Are they vaping? Are they smoking? Is there anything going on at home? Is there anything going on environmentally? Certain times of year? Is there heavy traffic? Have they got exposure to mould or damp in the property? All of those kind of things as well. So this is for the new diagnoses. First line is anti-inflammatory reliever therapy. If that's not working for them, add in low-dose MART. If that's not working, increase the dose of MART. And if that's not working, think about adding in Montelukast, or think about referring on, and that would be specialist asthma care at the Children's. The guideline includes doses, so a description of what is low, medium and high dose treatment for this age group. And this is just a slide to demonstrate the evidence of a MART regime. So this is the pooling of two studies that they did, so Sigma 1 and Sigma 2. The blue box there is patients that just had short-acting beta agonist as their reliever. And then across at the right-hand side, the red and maroon boxes show that it was about half the rate of exacerbations in the patients that had either AIR or MART therapy. So it does make a difference. And this is a study specifically in this age group, so not in the younger children. But the numbers in that study were small. So in terms of licensed treatments, we've got some treatments that are licensed for both AIR and MART therapy, and some treatments that are licensed for just MART therapy. We have a specific issue with the MDI, with the 100/3 MDI, and I'll come to that in more detail on the 5 to 12-year-olds, but all of the others are available. But A lot of this is dependent on inhaler technique and patients being able to use a dry powder inhaler. This is our only MDI, and as you can see, it's got half the dose of the long-acting beta agonist in there, so giving them the increased doses on a MART regime gives them a lot more steroid, and that's the issue that we have with that as a treatment option. I've put a list of websites at the end, and they link to the different resources. So this is the ICB Healthier Together. This is the basic MART asthma plan that we give out in clinic, and this is easily accessible and easily printable. This is the key bit that we talk through parents in clinic. So the traffic lights, you know, when to be happy, when to be a bit worried, and when to try and seek help fairly soon on there. And we write their specific treatment onto this as well. Take a picture of it, put it on the fridge, take it into school so that everybody's got a copy of this. The treatment recommendations in 5 to 12-year-olds are largely unchanged as a first line. So this is not jumping straight to MART. So we're looking at MART in the over 12s, but the first line treatment for the 5 to 12-year-olds still remains inhaled corticosteroids plus a reliever. If they are assessed to be able to manage a MART regime, if that's not working for them, then it suggests considering a MART regime, but there's quite a few kind of extra bits of care that we need to take. So there is still the option for adding in montelukast, for increasing doses, and for referring to us if they can't manage a MART regime. But the MART is now a treatment option, but not first line for the 5 to 12-year-olds. So on the standard route, it would just be starting with Clenil, adding in some montelukast, and then thinking about 1 puff of Seretide 50 or 2 puffs of Seretide 50 if things still weren't controlled. So still a BD regime with preventive therapy with reliever therapy when required. And this is our plan, which is also available on the ICB website. So this is our standard asthma plan we give out, and they've got contact details for us written onto here as well. And again, a traffic light system, similar symptoms to the previous one, but in terms of this is just basically taking your salbutamol when you need to, and how many puffs is safe to take of your salbutamol. The MART regime does have some evidence in this age group, but a lot less than we've got in the older age group. So most of what we've got is built on this study done in Scandinavia nearly 20 years ago now. But they did randomise patients and found that the solid black box on the right-hand side is the children on the MART regime, and they monitored the percentage of exacerbations that these children were having. So you can see, compared to both fixed dose inhaled corticosteroids and a fixed dose combination, the children with the MART regime were having much fewer exacerbations, and this did include children as young as 4. Another study, the Trexa study, slightly more recently, looked at similar and showed that anybody on regular therapy did better. So this is why the inhaled corticosteroids are still fine, but that the children on MART regime, the combined therapy was still were doing slightly better in terms of the exacerbation rate here. I know that it's reasonably common practice in adults to increase inhaled corticosteroids during exacerbations, and we do sometimes get children referred through to clinic who've been given this advice in primary care. The evidence in children is that this does not make a difference. It's increasing the long-acting beta agonist that makes the difference to their exacerbations rather than increasing the steroids. So this shows, looking at both the symptom score and the amount of short-acting beta agonists that they were using, that there was no difference in the patients who had the standard dose or the patients who had the increased dose. And obviously we're much more concerned in our patients about suppression of growth and adrenal insufficiency if we're giving steroids. So my take home from this is that we don't just increase a steroid alone. That's not oral steroids. If they need oral steroids, that's fine. This is do not increase a steroid-only inhaler in this group of patients. It doesn't work, and it could have quite significant effects for them. So the evidence for MART and AIR in this age group is based on that, mainly on that single study from 2006. It's in dry powder inhalers, which have got specific challenges in this age group, and we've sort of extrapolated the data for MDIs. You can see the strong evidence that increasing the dose of ICS by itself doesn't work, and we know that just having that would impact on the final height. The studies show it's about a centimetre difference, which is probably more important for boys than girls. Girls don't seem to worry that they're going to be a centimetre shorter, but for some boys that's quite important. And, you know, it's nice for everybody to grow as they should as well. So it's mainly that we counsel for, but if it doesn't work, there's still no point. So the MART regime as an MDI is not licensed in this age group, which is why the guideline very much emphasises the BD steroids as the preferred route in the 5 to 12-year-olds. And if you are prescribing a MART regime in this age group, you need to convince yourself that you're happy that you've tried other licensed treatments before. There's some suggestions for doses there, and I've got another chart that shows that as well. So that's what we're talking about in terms of low dose MART and medium dose MART in this age group. But this is where the technique comes in as quite important. So the lowest dose is the 100/3 MDI, and so obviously you'd be using an MDI via a spacer. We've tried our patients on dry powder inhalers. We're very happy that the over 12s can easily manage a dry powder. We've got ways of monitoring whether they're going to manage a dry powder, and Emma's just going to talk us through that.
Yeah, I think it's just really important that you are aware when you're prescribing a DPI, especially in the younger age group, that they can actually use it before you actually prescribe it. So in our clinics, and it's worth everybody investing in these, the in-check devices. So you can dial it up to whatever inhaler you want to give them, and you can just buy disposable mouthpieces on the end so they can have a go with it whilst they're with you. I know you've only got a short period of time in that clinic appointment, but if we want them to be compliant and adherent with the treatment and making sure that we know that they can take their inhaler properly, it's worth just having a go with one of these, or maybe in the pharmacy that works with you. We also, in clinics, especially with the turbohalers, we get these from AstraZeneca. So they give them us for free, and we've got bags and bags of them at the children's, and we go through inhaler technique at every appointment. So we're making sure that before they go home with a new inhaler that they know how to use it. They're all quite alarmed with this one because it always whistles when they do it, so they jump out the skin, but at least we know that they're using it properly. And we always, if it's a MDI, then we're very keen on the green aero chambers. We're big, we're lovers of this one. So these are all on the formularies now throughout the whole of Sheffield, and just making sure that you're all doing your tier training as well. So we are doing the asthma-friendly schools throughout the whole of Sheffield as well, but we really want everyone to be tier 3 trained. So I think it's free still, isn't it?
Up to tier 3.
Yeah, up to tier 3. It's quite a lengthy bit of time to do it. It's about 3 hours for the tier 3. But if you just go online on the Healthier Together website, all the information's on there. And we're quite happy. We'll put our email addresses up so you can email us and we can send you as much information as you need.
So this is the summary of the inhalers in the 5 to 12-year-olds, and this is just to emphasise why we're concerned about the MDIs. So they are suggested for use, but if we're using that maximum 8 reliever puffs a day, that child is getting 1,600 micrograms of the steroid component of that. So that is a lot of steroid. Whereas if they're just on the turbohaler or the easyhaler, which obviously technique-wise is quite tricky, they're getting much less steroid. So our request is that if you're looking at those red box treatment regimes, that you refer them into us so we can just have a bit more of a think and a bit more of a work through techniques and spirometry and things with them. So we're just being careful, really. The guideline includes the definition again for this age group in terms of what's low, medium and high dose. And these slides will be circulated, so this is just a summary of the different inhalers that are available for MART regimes. So this is not a complete list, but this is when we would suggest that you refer anybody on to us. So anybody requiring frequent admissions or lots of steroids, first of all. Anybody who is deemed uncontrolled on high-dose inhaled corticosteroids, despite those things being checked, so environmental triggers, the right thing being prescribed, the patient picking it up, the patient actually taking it, and likewise the same for MART. Anybody that's had an ICU admission should be seen in our clinics, and we would usually pick them up anyway, but if there's anybody that you think is missing, flag them to us. More than 2 courses of steroids a year, and as we've just said, that age group needing MDI MART, so we can just work through things a bit more carefully. Within the children's, we do have spirometry and pheno. If you're referring in for that, we don't have a testing clinic. They are coming to one of our respiratory clinic appointments and they're having that as part of that. So you're going to be charged accordingly for that as well, because we're not a diagnostic hub. And I think that's probably a wider discussion to happen at ICB level, given the increase in referrals. We also have exercise testing and bronchodilator responsiveness testing if they come in and need reversibility, if they show obstruction in clinic. We have inhaler monitors to check for adherence, and this is now linking with some apps and some reminders that the families have got as well. And we have our DA clinic, which is running this afternoon, where we've got a multi-professional approach to patients, and we have the biologics that we can prescribe. Emma and I run our transition patients. Oh, you've gone? Great. Run transition clinics within Sheffield, and we also do further investigations as needed, so bronchoscopy services. We have an exercise-induced laryngeal obstruction clinic and dysfunctional breathing clinics as well, and we're available for teaching and training. I would suggest, again, this is not complete, but this is sort of what we view our relationship together being, that we still want our patients to have an annual review, because I think it's really important to assess the salbutamol prescriptions particularly, and adherence to preventer medication as well. We don't have access to that, so that would be really useful. Flu vaccination, we recommend to all our patients. Please don't ever prescribe nebulizers. I'm sure that nobody does, but there's obviously alerts about that, and it's certainly not something that we've done for a very long time. Now, we wouldn't want children to prescribe salbutamol without some degree of preventer prescription as well, and I think it's really important that we discuss that lack of dose counters as well. If you're worried about patients, feel free to refer or discuss with us, and think about other routes of investigation or other problems that might be there. I've got the slide after this one is about the CARE study, which the Children's is taking part in, and we're going to start recruiting for soon. So that's a national study looking at MART regimes in that 5 to 12 age group, so that more evidence exists, and it's a sort of randomised process. And I've got a QR code for you to all scan so that you can send patients in to us. We'd like to work collaboratively for follow-up, so that we're not having clinics plugged up with these, and we can see the patients that you need us to see as well. And Emma and I are hoping to target some of the more at-risk groups as identified by the review at the end of last year. So those adolescent boys, and particularly the patients from slightly more deprived backgrounds as well. There's projects going on within Sheffield into air pollution, healthier homes, and we've got the inequalities group at the Children's as well, which is working together, and we're also trying to build links. Emma's mentioned asthma-friendly schools, but we're trying to work with families and communities as well. So this is the CARE study. I hope you can scan the QR code. So we are retrospectively identifying patients within the Children's Hospital. So anybody with asthma that's had salbutamol with or without inhaled corticosteroids is eligible for this, and they'll get randomised to either having MART therapy or air therapy or standard therapy as well. And it's run through Louise Flemings at Imperial, and should hopefully really influence practice in the future. And we're also going to put some adverts out so patients can self-refer themselves. That's my list of useful websites. So the asthma action plans and the MART plans are on the ICB website at the top. The National Asthma Bundle, which includes the training that Emma referred to as the second reference there. Moving on Asthma is quite a big website that some of our colleagues put together with more kind of information for the adolescent age group. And Asthma and Lung UK is obviously a great resource for inhaler technique as well. And that's our email addresses if anybody does want to get in touch with us. Any questions? No? Okay. Oh, yes? So what we know about mould is, so I have Ishak, the little boy that died in Lancashire, had infection with mould. So I think they actually found mould when they did cultures on post-mortem. We regularly, you probably do it as well, write letters for families in terms of their accommodation. Our bottom line is essentially that mould is not great for children's chests. So if they're in rented housing, be that private or housing association, we would advocate for that to be dealt with if the cause can be identified. So some of our patients are sensitive to mould in terms of a slight allergy, and we might get that on skin prick testing as well. But even without those two things, infection or sensitisation, we would advocate for properties to be of a reasonable standard. And there's various websites. So King's have got a good template letter. This patient is seen for respiratory reasons, and I would appreciate it if you could address the mould problem in the family home. But the specific reasons for that patient that died, we don't see very often in our population. Any other questions? Yeah.
Is there anywhere to direct schools to? I was chatting to the nurses in our network recently, and one of them raised the issue that they're getting lots of requests from one of their local schools for kids to have salbutamol inhalers to take to school. And one of them, I don't know exactly which children it was, but they said that the school kept on requesting lots for lots of the kids that were registered there, and they were giving them almost like preventatively, like giving them routinely every time they did PE.
They're Rob's patients.
And which seems like not good management of their asthma, but I just wanted, because I was going to get them to pass on which school it was, whether there's anywhere that we can direct schools to get.
So the National Bundle of Care for Children and Young People with Asthma has tiered training. The tier 1 training within that is for sports clubs, brownies, guides, schools. So basic level, quick training, and that's the basics of what they'll need. We absolutely don't advocate salbutamol pre-activity anymore, because if you were overusing that salbutamol, you don't know about control, and it's potentially a risk factor. It's potentially, I guess, a poorly controlled child. But that would be the first port of call for them. But also,
if it's a school within Sheffield, I'm more than happy for you to email me, and I'm happy to do the training and get them doing the tier training. All right.
I guess the elephant in the room is if we move everybody to MARC regimes, schools giving salbutamol is just going to get very complicated, and we're aware of that, and that will need to change. But for now, that's the advice. Thanks.